Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday edition. Our talk tonight is going to be Retinal Grand Rounds, a snapshot of a day in my retina clinic with Dr. J. Haynie. Dr. Haynie graduated from Pacific University College of Optometry and completed a residency at American Lake Veterans Hospital. His focus there was diagnosis and management of ocular disease. He serves as the Executive Clinical Director of Retina and Macular Specialists until 2018, at which time he joined Sound Retina in Tacoma, Washington. He is an adjunct clinical professor at Pacific University's College of Optometry, a fellow of the American Academy of Optometry, and a member of the Optometric Retina Society. He is a sponsor of a fourth-year internship for optometry students in his private practice. He's a clinical investigator and continues to be involved in clinical studies regarding retinal disease management, both as a principal and a sub-investigator. He is a published author and has become a nationally recognized speaker on advances in technology and the management of retinal disease. So with that, it's our great pleasure to introduce and welcome Dr. Haynie to our webinar series. Jay, please take it away.
Good evening, everyone. Thank you so much for the kind introduction. Joe, Greg, thanks for having me be a part of this webinar series. And again, I am Dr. Haynie, and these are my financial disclosures. And let's just jump right in to a first of our series of Grand Round cases. I've titled this, "Where Does This Pigment Come From?" So this is a 64-year-old female. She's noted a gradual decline in vision over the past few years. She has a very specific chief complaint that letters seem to look jumbled with reading. And when patients comment on letters looking jumbled, it almost certainly is going to be some form of macular pathology. Her medical history includes diabetes, hypertension. She's on medication for cholesterol, depression, and anxiety as well. So for someone in their mid-60s, a visual acuity of 20/40 is not necessarily what we would expect. Anterior segment evaluation, however, was unremarkable. She's got some early cataract, as we might see in folks in their 60s. And as we look at the retina photos shown here, I will magnify this here. This is the right eye. So she's in her 60s. She's got some macular pigment changes that are showing up kind of in the temporal aspect here. She's got kind of a gray, cloudy appearance, as we note on fundus imaging. And this appearance here is often much more appreciated on a high resolution digital photograph as compared to what you might see at your slit lamp. The other eye has very symmetric features. She's got some RPE changes and the same gray kind of shadowing here. So, with respect to macular disease, we've all, become accustomed to advances of technology. There's a lot of us now with OCT technology, and these are the OCTs that we have. And pay particular attention to the features on this OCT as described. Schisis-like changes or a splitting of the inner and the outer retina. There's also a draping of the internal limiting membrane. This is pre-vitreous separation. And these OCT images have actually become very characteristic for this disease that we are about to learn what it is. Fluorescein angiography is widely used in retina. However, with the dawn of OCT angiography, we have found ourselves leaning more towards the non-invasive OCTA in cases similar to this. But fluorescein angiography in the later phase, there's the hyperfluorescence or the leakage of fluorescein indicating a vascular disease per se. And so when creating a differential diagnosis, part of this is born out of clinical findings. The other part is going to be born out of medical history. So we include diabetic macular edema. She does have hypertension, and so we talk about retinal vein occlusion. Epiretinal membrane, some folks will look at the OCT and see that drape of internal limiting membrane and comment on an epiretinal membrane. She is of the age to have AMD, and therefore choroidal neovascularization needs to be on the list, as that's a very sight-threatening complication. But as we look at and review all of the clinical findings, this is a patient who has a condition we call parafoveal retinal telangiectasia, otherwise known as MacTel. In the literature, this can also be noted as juxtafoveal retinal telangiectasia. There's paramacular telangiectasia. So there's a lot of different names for this, but it's currently using the acronym MacTel. I like to use MacTel because my staff and myself can't spell telangiectasia. So let's go through what this entity really is. And I'm sure that there's a lot of folks on the call tonight that have seen this condition, but may or may not have known what it is, specifically from the OCT I showed you. So MacTel comes in two types. The typing of MacTel is important only in that unilateral cases are limited to the male gender only, whereas bilateral cases can be both men and women. So if you have a female gender and you think you have MacTel, it's probably something else or a mimicker, as unilateral cases are exclusively for the men. Clinical signs, as we saw in the photograph, they will develop early on, kind of a 1 to 2 disc area of retinal edema. Later, as the disease progresses, there's an abnormal kind of a dilated capillary appearance. Sometimes you'll actually see some microaneurysmal lesions. And then as the disease marches forward, as the chronic vascular leakage occurs, you will actually see remodeling of the vascular system, which gives this right angle appearance to the vascular system, which we have some great slides of. And then chronic macular edema, chronic diseases will oftentimes lead to some migration of the RPE, which is noted clinically as the pigment hyperplasia. So this is a case of early MacTel. This entity is thought to start in the 2nd or 3rd decade of life and then progress throughout life. This was a woman who was seen for a LASIK consultation and was not able to be corrected to a sharp 20/15 acuity, as we would expect with someone who's 30. And so we can see the early clinical features of MacTel, where you have the gray thickening. Very hard to appreciate clinically, shows up really well on digital photography. As I mentioned, the right angle venules, as we see here, this is an early phase angiogram of a patient with MacTel. So if we look in the very temporal aspect, we're starting to see some leakage of fluorescein, and here is the right angle changes. This is the remodeling of the capillary system due to the presence of chronic vascular leakage. OCTA is a great tool, as I had mentioned, very quick, non-invasive test that just takes a couple of seconds to acquire a very good vascular map. And so we use this a lot. And here's 2 cases of MacTel. You can see very well the remodeling and the right angle changes within the venous system. Here's another OCTA where you can actually see the telangiectatic vascular system in the temporal aspect and the corresponding OCT, again, with the characteristic inner retinal changes, kind of like a schisis look. These patients can have this condition pre or post PVD. This is a little vitreous adhesion, kind of a stage 1 PVD. There's a good article for reference if you want to read a good article, which talks about the update. I was very fortunate to be involved with the authors that you see there, and so this is an article that you can read to fill in anything that you don't learn here tonight. And let's just go through the 5 stages. So as I had mentioned, MacTel will typically start to develop in the 2nd or 3rd decade of life. And at stage 1, where our LASIK patient was, They are most patients are generally asymptomatic. They are unaware of the disease entity, but you start to see the loss of retinal transparency, the gray characteristics in the macula. This moves on to stage 2, and the time between stages can be anywhere between 5 to 10 years. It's a very, very slow process. Stage 2 is just more of stage 1, where this loss of retinal transparency becomes much more apparent on clinical examination. This is when patients may start to have a little bit of blurry vision, maybe slight metamorphopsia. Stage 3 is really when symptoms start to begin. And again, stage 3, this could be in the 5th or 6th decade of life, but you start to see the vascular remodeling, the right angle changes within the capillary system. We've got some microaneurysms and then pigmentary changes. And this is when patients really start to report a decline in vision. Now, the visual decline is highly variable, but usually at stage 3, patients are to the 20/50, 20/70 range in acuity due to the chronic vascular leakage and what that does to the outer segment of the photoreceptors. Stage 4 is when you start to see the proliferation of pigment. This is where patients will oftentimes develop scotomatous changes in vision. As you remember from the case that we are presenting, she has stage 4 given the pigment hyperplasia, and one of her chief complaints was letters are looking jumbled, and that's primarily because of the scotomatous changes in vision, the saccadic movements that are made to try to see the entire word creates the impression that, you know, the letters are jumping around on the page. And then the final stage in this disease entity, due to chronic vascular leakage, due to impact on the retinal pigment epithelium, these patients are at risk of developing a secondary choroidal neovascular membrane. This is treated as we normally treat choroidal neovascular membrane, and this is the only complication of MacTel that is amendable to therapy with treatment with anti-VEGF. We can't treat any other entities, and although treatment for CNV is the only treatment, by this point, patients have really become visually impaired and oftentimes are nearing or approaching legal blindness. This is a choroidal neovascular membrane secondary to MacTel as seen with OCTA. We have the flow map down here on the left, and we've got this red, which indicates blood flow through this neovascular complex. I really like OCTA when it comes to a very quick diagnostic tool for vascular disease as well as AMD. Here's another example of a case. And what we use OCTA for a lot in patients with choroidal neovascularization is the big question in retina in treatment with anti-VEGF is, you know, when do you actually stop? It's very apparent when we start treating patients, but when do you actually stop? And so we will use OCTA to track lesion size. And here's our patient with MacTel. This is after 3 Avastins. This is after 7 Avastin treatments. And you can really appreciate the regression of that neovascular complex. We will, my retina surgeons will treat CNV with secondary to MacTel until there is 3 serial OCTAs that look exactly the same. And then there's the convincing notion that the regression of CNV has taken place. But it's a great tool to track evolution as well as regression of disease in response to treatment. One of the kind of cool things about MacTel is at any point you can see crystal-like changes in the retina. Adding this now to your differential diagnosis of crystalline maculopathy. Most of you are familiar with what we know to be talc retinopathy. I just actually saw a case of that on Friday. It was a little odd when I asked the patient if she's still a heroin user. It's interesting what we see when we look in the eye, but adding MacTel to your differential diagnosis, although I will tell you that the difference between crystalline maculopathy in MacTel as compared to talc retinopathy is the crystals are extravascular. They deposit just below the internal limiting membrane. There's really no clear etiology or cause as to where these crystals come from, however. So poll question number 1.
All right, Jay, it's launched. The only complication of MacTel is potentially amenable to treatment. At this time, macular edema, crystalline maculopathy, vascular telangiectasia, choroidal neovascular membrane. And Jay, I added this. I know it didn't come, but our surveys, people have asked for us to put in there. I'm not sure. That's why I'm here. So that's why that's the other one that you might see.
Jay, I'm sorry.
Go ahead, Joe. Go ahead, Joe. Then I'll make my comment.
Talking about talc retinopathy, a lot of it has to do with your patient population. There was a period of time early in my career where I consulted in the prison system in Philadelphia. And the incidence of talc retinopathy that I saw was probably 15-20% of the population. So I've actually seen quite a bit of that, given the situation.
And my comment was going to be, go ahead, Jay.
Yeah, it's kind of interesting that, it lives forever in the retina, right? I mean, unlike any embolic disease with cholesterol, that goes away, but, talc is there forever.
And my comment was going to be, a lot of people out there might think that this is kind of like a, well, yeah, I'm never going to see this. It's, it's not rare if it's in your chair. I can tell you with the advent of, OCT and, OCTA especially, I was trying to figure out how often do I see this in a year? And I bet you we have 5 docs in our practice, and I bet you that we see this once a month. Where times before I'd be like, especially with the early stages where you really can't really see that retina becoming excavated, in that inner and outer retina. You'd kind of look in there and say, look, something like it's going on. But now with OCT, we're catching these at a much an early stage that's out there. So I'm glad that you're presenting this, because this is not as rare as people think it might be. So I'm going to share the results here. You'll see them. And you'll see here that 12% said macular edema, 7% said vascular telangiectasia, and the majority said the choroidal neovascular membrane.
Jay, before you go on, I just want to throw a question out there. I think some people might wonder about on OCTA. When you're looking at an area of telangiectatic vessels, how do you differentiate that from choroidal vessels, a choroidal neovascular membrane? Because to some people who are not experienced, there may be, they may overlap a bit.
That's a great question, Joe, and I'm glad you brought it up. So how do you differentiate, telangiectasia in our case from CNV? Well, with MacTel, the choroidal neovascular membrane will generally start above the retinal pigment epithelium. The telangiectatic vessels are intravascular in the inner retina. So most of the OCTs will have the slab function, to where you can look at superficial retina, deep retinal complex, avascular, and RPE. In the early phases, you'll see telangiectatic vessels within that deep the deep choroidal, or the deep capillary plexus, which is just below the major retinal vessels.
Excellent. Thank you for clarifying that.
It's kind of inner retina versus outer retina, right, Jay? The inner retina is where the telangiectatic vessels are occurring up there in that inner retina, and then the choroidal neovascular membrane is kind of down there at that choroidal level. Is that kind of a
correct?
Okay. Yep.
Correct.
Yeah, we see a lot of it at the practice. Having OCTA really helps it out. So to really differentiate that. Great. It says here from a patient, did he say 20% of patients had talc retinopathy? And here it says talc retinopathy, but it's talc retinopathy, just FYI.
Oh,
no.
I said that because I was seeing prisoners in a prison system.
It's your demographic, Joe.
Exactly.
The demographic. Okay, we'll move on.
Thanks, Jay.
You give me back my power to move.
You should still have it.
We don't take it. You probably just click somewhere else. Just click on your screen and you should be able to get it back.
So as we just learned, the only treatment, the only complication of MacTel that is amenable to therapy is the choroidal neovascular membrane. But through my career in retina of nearly 3 decades, we've tried everything from Diamox to topical agents for the presumed intraretinal edema that can be associated with MacTel, laser photocoagulation for the telangiectatic vessels. We thought photodynamic therapy might be an option when that came out. Injections of steroids, injections of anti-VEGF, but unless there is a choroidal neovascular membrane, this entity is thought to be not amenable to treatment. However, there's good research as to the use of carotenoids with patients who have MacTel. And so as a provider, I think we're obligated to put our patients on, a good carotenoid supplement if they carry the diagnosis of MacTel. Although there is no current therapy available, I would also like to bring your attention to the phase 3 clinical trials that are going on very close to me in Portland, Oregon. Neurotech Pharmaceuticals, Renexus. This is in phase 3 clinical trials, and from word from the internal investigation, the FDA is reviewing this at the current time, and there's word out that it has been shown to be effective in some patients with MacTel type 2. And so watch for this as a potential treatment modality for your patients who have MacTel. And then kind of one final comment about MacTel and our low vision providers that are with us tonight, if any. And if there are, I want to thank you for your service. But this is one of those disease entities that we know where they start, we know where they're going to end, and we know what we can't do for them. And so I always encourage my patients with MacTel to visit kind of a low vision provider when they are, 20/50 to 20/70, because we know that it's inevitable that they may become functionally visually impaired. So think about an early referral to one of our optometric colleagues who specialize in low vision when they're starting to develop, functional vision changes, 20/50, 20/60, et cetera. Now, to Greg's comment about, seeing this a lot in his era, I truly believe we see this more often than not. And, this is a patient, and I see a lot of patients with MacTel end up coming to me as a second opinion. And so I just posed this real quickly, is this truly AMD? This patient presented for a second opinion. He was receiving injections, wanted to come in for a second opinion. This is what his retinas look like, and we can sure now appreciate the loss of transparency, the pigment hyperplasia that we notice. There's the OCT images. There's no evidence of AMD. The RPE layer is as pristine as mine is, but you've got those characteristic interretinal changes. So, a lot of these patients are diagnosed with AMD, whether it's because of the, pigment modeling you see, but this is certainly something that I would move to a carotenoid as opposed to a red supplement. So watch for your patients who enter your practice with a diagnosis of AMD. They might have a mimicker known as MacTel.
Hey, Jay, before you move on, there's a question in there from Melissa. It says dosages of zeaxanthin to lutein that you would recommend. I'll let you make a comment, and then I have a comment most likely after you. So please, as our speaker tonight, please go right ahead.
So the dosage of lutein to zeaxanthin, there's a wide variety of what's out there on the shelf, but most of the clinical trials that have looked at the therapeutic dosage of lutein zeaxanthin, it is a 5-to-1 ratio. 5 lutein, 1 zeaxanthin, and the minimum dosage is going to be 10 milligrams of lutein, 2 milligrams of zeaxanthin. So what I tell patients is you want a minimum dose of 10 milligrams of lutein, which will have 2 milligrams of zeaxanthin, and anything over that. 20 is very common, 25 is common, 40 is common. Anything over 10 is harmless. And so I tell people, don't run all over the county looking for 10, anything over 10, but just don't get, there's products with 6 out there. That's not therapeutic.
Yeah, that 10-2 ratio. And just, just I want to point out, I've been doing a lot of, about 3 or 4 years ago, my patients asked me to kind of look into some of the nutraceuticals that are out there and what recommendations. And, a 10-2 ratio is a great number to do. And remember, carotenoids are hanging out in that inner retina, and that's right where this disease is. Those carotenoids act as a second lens, helping to focus, right? So that's one of, there's kind of 3 lenses of the eye, if you think about it: the cornea, the lens, and then the macular pigment, and really helping the acuity out. But then it really helps also with sequestering those free radicals. But I'm also a big supporter of the disease of being able to treat that outer retina. So, using resveratrol, catechins, quercetin that are out there. You kind of may have a full, maybe we can do some other retina kind of nutraceutical talk at some point. But I agree, you got to be doing lutein and zeaxanthin at the minimum, at that 10-2 ratio or that 5-1 ratio. But also, guys, do some digging on resveratrol, quercetin, starts with a Q, and catechins. That's what's in green tea. And I like to do a kind of a full retina support. But thanks for clarifying that for us there, Jay. Jump into the COVID.
Sure. So who would have thought we would still be sitting where we are in 2021? But, reality, it is what it is. And, with respect to, COVID, we've seen a lot of cases that have gone awry as a result of patients not seeking medical care, the diabetic population, and largely, for fear that they may expose themselves or contract COVID, they kind of hunkered down in 2020, and we saw a lot of cases of, proliferative diabetic retinopathy, vitreous hemorrhage, traction detachments. Very sad in the AMD population. These patients went without injections for 3, 4, 5, 6 months and lost functional vision. That's how it's impacted, a lot of our patients. But, I'm convinced that that COVID has contributed to, the diagnosis of the retinal disease. And, I was talking to Greg, when we were in Orlando about COVID, and there's weird things going on in the retina as a result of COVID. And so I think we're going to start to see a increase in kind of database, if you will, on, retinal findings secondary to COVID. OCT features are pretty characteristic. So I'm going to go through a couple of cases where, I'm convinced, and it's been confirmed, that COVID has actually caused issues in the retina. So we'll start with a 38-year-old African-American male who developed sudden vision loss late in November of 2020. Visual acuity was very poor, legal blindness in both eyes. And his medical history, he was a type 1 diabetic of 12 years duration, also contracted COVID-19. We know with type 1 diabetes that at 12 years duration, some may have retinopathy, but, a lot of them still have a pretty pristine looking retina. And as he states, his vision was perfect until, the summer of 2020. And then certainly by the fall, he was legally blind. He's a CNA, and April of 2020, when this all started, he was working in an adult care facility that was swept by COVID. He contracted the virus and tested positive in June. Not only was he tested positive, he was hospitalized with congestive heart failure, renal failure, thought to be, embolic of etiology of the CHF and renal failure. And upon discharge from the hospital, he noted a sudden loss of vision in each eye. So fluorescein angiography of our patient. Here's the fluorescein angiography of our patient. And, this is kind of interesting in that with fluorescein angiography, we see, the background will commonly look somewhat gray. This is jet black or dark. The only vascular perfusion that we have is kind of in the papillomacular bundle area, maybe a little peripapillary perfusion, but everything else is dark, which is, complete obliteration of the capillary plexus and absolutely no perfusion. This is more of a wide field angiography that we have on our patient, which you can really now appreciate here in the left eye, the ischemic nature of the posterior pole. The right eye is kind of blocked off. You may all start to see these in your photos. This is a mask artifact. When the camera was, trying to take a picture, the patient's mask was in the way. But the interesting thing about this angiogram is we know that fluorescein angiography of a diabetic patient, the non-perfusion, as pointed out here, will typically begin in the peripheral fundus and then march its way to the posterior pole. So even with severe diabetic eye disease, patients will generally have maintained perfusion to the posterior pole until the very end. But in contrast to our patient, this knocked out his posterior pole circulation and spared the peripheral fundus. So it's unlike what we typically see with diabetes. So this was the first thought that maybe COVID's having a contributing factor to, diabetic retinopathy. So having that said, let's go to poll question number 2.
And Jay, I want to say thank you. I know I saw you back in Orlando at Vision Expo East. One of my personal asks was for you to put in cases on COVID. So thank you for doing this.
Sure, I think it's I think it's going to be important, and as we review these cases, I've got some pretty good recommendations for the audience on how you work up a patient that may have had COVID-induced retinopathy. And there's no harm done in drawing a blood test. The dilemma that we have now is the blood draw for COVID. If you're looking at the the IgG of COVID-19, if they're vaccinated, they're already going to have it. But there's still a lot of unvaccinated people running around, and we'll talk about what I do when I see these patients as we close. But no worries, Greg.
Yes, I mean, I'm sure there's other docs out there in the profession that, could have done the lecture with the COVID, but I couldn't think of anyone any better. So thank you for doing that again. So
sure.
All right, we're going to now stop sharing the poll. We'll end it, and I'll share the results so that you can see the results. And you can see that 10% said non-perfusion involved in peripheral retina, non-perfusion involved in the posterior pole was 15%, and then 11% non-perfusion spared peripheral, and then both A and B are correct, was the majority at 59, and we had a handful of people say they weren't sure, and that's why they're here.
Okay, I like it. Everybody's learning. Okay, so let's talk about another case. 26-year-old Hispanic male developed acute shortness of breath, fever, cough, recent exposure to COVID positive patient. Due to symptoms, he was tested for COVID-19 when presenting to the emergency room with secondary pneumonia. So he became symptomatic of COVID, presented to the emergency room, and unfortunately his disease progressed, requiring put on a ventilator. This is a otherwise healthy individual. His medical history did not include any known entities to this date. So this is a COVID only medical diagnosis at this point. Here's his chest x-ray. I was able to get the chest x-ray from the hospital. I don't look at a lot of chest x-rays. I kind of put this in here for fun. But we have a normal chest x-ray on the left. And, patients who have developed pneumonia, respiratory disease from COVID, have developed these very characteristic kind of foci ground glass looking opacities, as we see in our patient here. Vision was doing fine until discharge from the hospital. So maybe both of these cases were fine in the hospital. Maybe they should have never left, huh? So 1 week post-hospital discharged, he developed sudden vision loss in the right eye. And he also described kind of purple spots in the vision of his left eye. For those of you who haven't noticed this, but when patients describe these transient bluish purple spots in vision, it's almost certainly related to a vascular disease, and I include that in my differential diagnosis of amaurosis fugax, these little purple spots in vision. So as we see from the vision, 2100, 2025, here's the fundus photos upon presentation. You'll notice that he's got, diffuse intraretinal hemorrhage involving all quadrants in the right eye, and he's got similar features in the left eye to a lesser extent. The interesting feature here is when we look at these photos, we think of a central vein occlusion. Central retinal vein occlusion is what we diagnosed him with, but look at the optic nerve. Most patients who have a severe central retinal vein occlusion will have elevated blurred disc margins, and his margins on the optic nerve were normal. It doesn't mean that he doesn't have a CRVO, but it's a little bit atypical than we see. And furthermore, it's very atypical to see this in someone who's 26 years old. OCT images of each eye, we have, the characteristic, diffuse intraretinal edema. There's a little subretinal fluid in the right eye. This is a very characteristic OCT that you'll see in patients with central vein occlusion. But if we look at the OCT of his left eye, very, very normal. Now, I'm going to draw your attention to the inner retina, and we have the nerve fiber layer, and then we have the outer plexiform layer, and there's all these little white opacities that are kind of showing up in the inner retinal layers. These are presumed to be potentially OCT features of COVID-19. So look very carefully at your OCT images of your patients who've had COVID. You might find some of these. And the question is, are these going to go away? The answer is we don't know yet. So this patient had angiography. And here's another sense. The first patient with COVID had ischemic disease in the posterior pole. He was a diabetic. This is a patient who's got peripheral non-perfusion, which you will generally see in patients with straight up venous occlusive disease like a CRVO. The other unusual thing is we've got some arterial leakage in the later phases denoted by these yellow areas. So you've got not only the venous system is involved, you've got the capillary system, which is non-perfused, and you've also got arterial leakage in the later phases, which is really not characteristic of a classic CRVO unless it's very, very ischemic. So he was diagnosed with an impending central vein occlusion, or a central vein occlusion of the right eye. This was based on angiography. My retina MDs I work with made this, and they also diagnosed him with an impending central vein occlusion in the left eye. He had initiation of anti-VEGF treatment in both eyes. The thought would be that he's got a vaso-occlusive disease, potentially from a systemic etiology of COVID, and he is going to be treated in both eyes, and he's actually doing very well. But the next step that I took with this patient is knowing that individuals with COVID-19, they've got coagulation abnormalities. And I was very surprised in doing my research that nearly half of patients with COVID have died due to a pulmonary embolism and have also had subsequent deep vein thrombosis, or what we know as DVT. So we are very aware that COVID is causes hypercoagulable states. And in this patient, I ran a hypercoag panel, which confirmed pretty much every anomaly that you can have with a hypercoag panel. We get a protime, we get, the PTTs, the INRs, you get homocysteine levels, protein C, protein S, and he was found to be positive for a hypercoag disorder. These patients are generally then referred to hematologists for management. He was started on anticoagulation therapy. as a result of the hypercoagulopathy. Now, interestingly, with him, he's responding very well to anti-VEGF, and my surgeons, I don't have a follow-up OCT. He missed most of his follow-ups. He only had one shot. But the interesting comments that my retina surgeons have made is his fundus findings have resolved very, very rapidly, unlike what you would see with a typical central vein occlusion. And the theory is the coinciding anticoagulation therapy he's on, Coumadin, has really proved beneficial to increase vascular perfusion, etc. So there's your second one. And we'll end with this one here in our COVID series. But this is a woman that developed sudden vision loss of her left eye 2 weeks prior to seeing me. Her medical history includes hypertension. She believes that she contracted COVID. She said, I had all the classic symptoms of COVID, but I never had testing for COVID-19. My question to her was, why weren't you tested? She said she called her primary care physician with classic symptoms. Primary care physician said, you probably have COVID, just quarantined for 14 days. You don't need to get a test. And that was kind of the, how people were looked at early on in the pandemic. She also had glaucoma, hypertension. The interesting thing with her is the magnitude of vision loss, hand motion vision loss in the left eye. She had fine rubeosis on the pupillary margin. She had early neovascularization of the angle. So she had early rubeotic disease. And here's her picture. So looking at this fundus photo, we see what most of us would jump to diagnosis of a central vein occlusion, and I would agree with that. We've got intraretinal hemorrhage in all quadrants. Again, look at the optic nerve. Maybe there's slight elevation and blurred margins, but you don't see kind of the vascular engorgement and tortuosity that you will typically see with a central vein occlusion. So here's another kind of an atypical pattern of retinal hemorrhages. Where it got interesting was with her OCT imaging. So I've showed you images of a CRVO, and I'll show these here in a minute, but OCT imaging of her did not come back how I expected it. So what I expected when I saw this patient here is I thought we were going to have profound intraretinal edema in the macula just because of kind of the grayish cast we see on the photo. But that's not what we saw. What we saw was a very hyper echogenic trait of the nerve fiber layer. Unlike you'd ever seen before, there is the increased retinal thickening here, and the darkening of the outer retina and the photoreceptor layer is not so much retinal edema per se, it's more of a shadow from nerve fiber layer edema that you will typically see in a patient with an artery occlusion. So here's a comparative OCT of a patient with a CRVO. This was our COVID patient. And then what you see with an artery occlusion. Artery occlusions will develop, you'll get, robust thickening of the nerve fiber layer. You get a shadowing effect at the outer retina. And our patient actually had more nerve fiber layer edema than intraretinal edema. It was really unusual. So based on fundoscopic appearance, anterior segment rubeosis, she was diagnosed with an ischemic CRVO by the retina doctor that saw her. And based on OCT imaging, she was also diagnosed with a combined retinal artery occlusion. So here's a patient who presented with what appears to be consistent with simultaneous artery occlusion and vein occlusion. And we know that this is very atypical. It's very rare to have an occlusive event involving the arterial and venous system alike. So what did I do when I saw this unusual case? She told me that she thought she contracted COVID. And so I thought, why don't we test her for the antibodies? So she had positive IgG for COVID-19, confirming that yes, in fact, she did. But she also had elevated homocysteine and a decreased protein S function, which is consistent with a hypercoagulopathy. So here's another retinal disease manifested by potential hypercoag states. So she was also started on systemic anticoagulant therapy. She's had initiation of anti-VEGF, and here's how she's responding. So here's where we started. Hand motion vision. This is following 2 Eylea treatments. She's had a significant reduction in nerve fiber layer edema. The retina has really settled back into place. There's a little bit of outer retinal disruption here from the ischemic event. But I bring your attention to the en face image of the OCT in the lower left. This is only 8 weeks from event and almost complete resolution of the intraretinal hemorrhages. And this is following the same pattern as our last patient where they had the hypercoag state. So we treat the retina with anti-VEGF, but keep in mind these hypercoag states can be contributory. And so in conclusion with this COVID, we know that the spectrum of disease is becoming more recognized. There's patients who are asymptomatic, some are going to have mild symptoms, and some go to the acute respiratory distress syndrome. Retinal vein occlusion is not yet well documented as a potential complication. And when I did kind of a quick review of the literature, I only found 1 documented patient who has a confirmed bilateral vein occlusion from COVID-19. So here we have 3 cases, in the great city of Seattle, where we think that COVID-19 played a role in it. So, when we talk about, I'm gonna go back just a minute. So what I wanna, the take home message of these cases is, when we have patients with central vein occlusion and they're under the age of 50, most of us are gonna recognize that that's not normal, and you do a workup. You do some laboratory workup, which includes, the hypercoag panel. Do they have a blood viscosity disease, I call it? We know about factor V Leiden as being common. But now we have clear evidence that COVID-19 is associated with embolic thrombotic disease. And so I encourage all of you that if you have retinal vein occlusions in patients who have contracted COVID-19, please get a hypercoagulopathy panel, because part of their treatment may be systemic anticoagulants like Coumadin for a period of time. So with that, let's go to the poll question.
So the poll question is launched. Workup for acute vaso-occlusive disease in a patient with COVID-19 history should include what? Color vision, hypocoagulopathy panel, visual field, gonioscopy. I'm not sure. So Jay, help me out while this is rolling in here. On an OCT angiography, where would we see, without COVID-19, most likely affecting first with capillary shutdown? Would it be posterior pole or periphery? And then what's the correlation? Just help me out, because I got a little bit lost. Are we looking for like peripheral in the COVID patient? Can you just walk me through that?
So specifically with OCT angiography, it's you're going to see capillary non-perfusion. It's going to vary dependent on the disease. The cases that I presented, typically with diabetic retinopathy, non-perfusion starts in the periphery. Typically with a retinal vein occlusion, you can have posterior pole and peripheral. The point of the angiography that I showed and the comments about the ischemic nature to the posterior pole is, with diabetes alone, it starts in the periphery and marches to the posterior pole. This was very unusual in the COVID case, where having diabetes, the peripheral retina was very perfused and it was exclusively posterior pole. So there's theory that he probably had occlusive disease involving the ophthalmic artery, which knocked out the posterior pole. So I guess to your question, Greg, capillary non-perfusion and ischemia can happen anywhere in the eye for any reason. It was just the unusual nature of how it presented in the diabetic patient, which led us to believe that it was a COVID COVID contributor.
Kind of like a comorbidity type of thing.
Exactly.
Perfect. So when the sharing of the poll has already been ended, just so you know, Jay, I'm not sure if you saw it.
I did.
97% of the people nailed it with the
Good.
coagulopathy panel.
And if you're unsure on what to order with a hypercoagulopathy panel, I generally lean pretty heavily on the PCPs to do the test, largely because I don't order any test that I'm not going to manage the results of. But in these cases, I wanted to make sure it got done. So lean on the PCPs. So here's a fun case, which is kind of a head scratcher. And, this is one that it's a case where, you look back at how you manage the patient, and, sometimes years later, things start to make more sense to you, largely because of, attending webinars and listening to great speakers. You get smarter, right? But let's look at this one. So how low is too low? So this is a patient that actually moved to the state of Washington, and his history was that he had been treated for complications of diabetes. He had poor vision in the left eye since undergoing treatment with laser. You have some of these patients that say, I was doing fine until that retina doctor did laser on my left eye. Now I don't see anything. And so he's had poor vision in this left eye for many, many years. His medical history, he's diabetic, hyperlipidemia, sleep apnea. I was the one that diagnosed his sleep apnea. You probably all, if you haven't heard me lecture about sleep apnea, I'm a huge advocate on sleep apnea. And he was, again, reminded us that he had some laser treatment for leaking blood vessels in the retina. He also had a history of steroid response glaucoma following some of the treatment that we offered him. Current medications. I put this up here in this format to kind of look a little bit odd. And the reason that is because when you have patients with macular edema, look at the medication list, because there are known medications that contribute to macular edema. We know about niacin. We know about the pioglitazone or Avandia actose for treatment of diabetes. We know prostaglandins topically can induce macular edema. We know Plaquenil and tamoxifen can create maculopathies. So, when you look at patients' medication lists, pay particular attention to those drugs that may ultimately contribute to the maculopathy. And certainly if you've got a patient with macular edema, you want to get them off all the drugs that can contribute to it. His diabetes was very well controlled. I mean, he had a fasting glucose of 85 to 105, great blood pressure, just a pretty healthy individual all around, pseudophakic. But looking at how he would present to us, his vision was all over the map. In March of 2011, all the way to April of 2012, his vision was all over the map. You think about, glycosylated hemoglobin and, sir, you need to get your blood sugars better controlled. We all jump to that when patients say, my vision is just foggy all the time. But then there are times it gets better. We can see here that he's got a potential of 20/25 in his right eye and even a 28 in his left eye, but he's all over the map. Now, these vision measurements were I went back and got these out of his chart. This is without any treatment. We're not treating him to make him better. We didn't treat him in June of 2011 to get him better by August. This was after everybody had thrown in the towel on this patient. When he would come to the office and his vision was bad, you can clearly see from the time domain OCT that he had diffuse intraretinal edema. Vision was bad. But through treatment, most of everything that we did or my surgeons did was proven refractory. And there were times when we would just forego treatment because nothing worked. And he would show up 2 months later looking like this. There's no treatment between these two visits. But for some reason, his retinal edema is essentially gone in the right eye and clearly better in his left eye. So he would toggle back and forth between these two, okay? So the management that we went through to try to get him stable included, I stopped his Avandia. I was convinced this is why he kept having macular edema. That did nothing. I diagnosed him with sleep apnea and was very convinced this is going to create a stable nature for you. That did nothing. He was treated with Avastin. That didn't work. He was treated with Kenalog. Pressures went to 45, hence the steroid glaucoma. He was put on oral prednisone as a final step. Sir, there's nothing else we can do for you. One of my retina surgeons said, let's put you on prednisone. All that did was drive up his blood sugars. That didn't work. But he did say that, you know, doc, when I was treated with that drug that caused all those floaters in my vision got really, really good. And then I was referred to a glaucoma specialist because of my pressures. And ever since I've been on glaucoma treatment, my vision's just terrible all the time. So when his eye pressures went to 45, he was referred to a glaucoma specialist who diagnosed him with advanced open-angle glaucoma based on visual fields. So let me show you his retina. Okay, first of all, here's his laser spot in his right eye. He never told us he had a laser in the right eye because it didn't change his vision. But he does not have any real evidence of diabetic eye disease. Okay, here's his left eye. Mid-peripheral fundus looks great. He's got a laser scar here in the papillomacular bundle. He's got a circinate ring of lipid because he's had chronic macular edema, but he does not have any features that would explain, you know, diabetic eye disease. And furthermore, why was he getting laser treatment? I'll tell you why I think he got laser treatment. For a peripapillary neovascular membrane is probably why he had laser treatment, and the retina surgeon heated him up a little too much and took out the papillomacular bundle. So that's why I presume he had it. Nothing to do with his diabetes. Here's the angiography, which is just highlighting laser scars, but there's no non-perfusion. There's really no microaneurysmal changes. Here's the other eye, which is just staining of his laser scar. Everything else looks really pretty good. So, you know, when making his diagnosis, you know, it was kind of challenging because he really didn't have diabetic retinopathy, but he had macular edema. We didn't know why he was having macular edema. So this was his starting diagnosis of transient cystoid macular edema in a diabetic male, okay? But question was, is it related at all to his diabetes? Everybody kept honing in on it's your diabetes, it's your diabetes, it's your diabetes. He had laser treatment for leaking blood vessels from diabetes. So my question was, is this shift in macular edema at all related to diabetic retinopathy at all? Now, going back to when he had the induction of high eye pressures, I mentioned that he was referred to glaucoma specialist. Glaucoma specialist ran visual fields. And as you can imagine, from this, there's going to be a visual field defect, right? It's going to be a substantial visual field defect. So the glaucoma specialist diagnosed him with, you know, severe primary open-angle glaucoma and said, sir, based on visual fields, your eye pressure needs to be below 10 or you're going to lose vision from diabetes, which is really what started the problem with his transient cystoid macular edema. Okay. So in following this patient for several years, you know, I made the observation that when his eye pressure was elevated, his vision and his CME was always better, and he was very happy. Now, what happened? So he would come and see me, and I would put him on topical prednisolone because we knew steroids worked. His macular edema would get better. His pressures would go up. He would go back to the glaucoma specialist and add another eye drop. And he was on maximum therapy, including Diamox at one point, to bring his pressures down. And then he would come back to see me. His pressures were 7, 8, 9, 10, right where the glaucoma specialist wanted it, but his vision was terrible, okay? So I tracked his vision as it correlates to the eye pressure, and it was very apparent that when he saw good, his pressure was high, and when he saw really bad, his pressure was low, which is called hypotony. So when your pressure goes low, you can develop hypotony maculopathy, which is typically associated with folds in the retina and choroid, and then significant cystoid macular edema. So I did a diurnal. This is the only diurnal I've ever done in my whole career. And I know that there are people out there, including Greg and Joe, say, Jay, you didn't do it right. I know I didn't do it right. It was supposed to be every hour. This was the best I could do. So I did a diurnal. He came in at 8 o'clock and I checked his eye pressures, and we could see that his vision got better, and then it started to slip, and it correlated exactly with his eye pressures. So I was convinced at this point that hypotony, or lowering of the eye pressure, resulted in the development of cystoid macular edema or hypotony maculopathy. So the question is, how do we manage this patient? So to kind of fill you in on what happened with this patient, he was bouncing back and forth between me and a glaucoma specialist. And, I respect the intelligence of anybody that I deal with. But, he got to a point where the glaucoma specialist said, if you keep seeing Jay, you're going to go blind. And his answer to the glaucoma specialist was, I'm going blind with what you're doing too. So I like Jay. I'm going to go see Jay. So he signed off on the glaucoma records and basically went AWOL and came to me and said, I'm not going back to glaucoma specialist. Remember, his visual fields were very, very poor. So I had to do my diligence, and he's had repeated visual fields now for 10 years. They haven't changed at all. I'm convinced his visual field tests were related to his laser treatments. So the management. So what do we do with this patient? Can't let his pressures go too high, but we also can't treat his eye pressure and bring it down too low. So here's how we manage this patient. Every morning, this patient puts a drop of prednisolone in each eye. Every 3 months, he sees his optometrist for an eye pressure check. And every year he comes and sees me. And from the moment we started this therapy, probably 8 years ago, his vision has been stable at 20/25 in the right eye. His visual field and RNFL analysis, etc., is exactly the same. He does not have glaucoma. I put him on 1 drop of prednisolone just to keep it in the low 20s. I'm nervous about pushing it into the high 20s or low 30s. So, this is a case of where sometimes the eye pressure getting too low can actually contribute to a coexisting retinal disease. So with that, why was this patient's macular edema worse? Was it related to hypotony? Was it diabetic retinopathy? The use of Avandia? Sleep apnea? I'm not sure. That's why I'm here.
And Jay, we have a question that rolled in. While you were doing this workup, were albumin levels ever checked?
No.
And then my would be, and I don't know albumin levels that well. Mine would be, one, I know malnutrition is part of it, but also kidney damage and diabetes. So Dr. Shovlin, if you want to, Dr. Shovlin, as you know, is one of the past presidents of the American Academy of Optometry, brilliant mind out there. If you have any thoughts, Joe, that you want to type in there, I can certainly read them. Thanks.
Yeah, that's
Did you take the patient off of? Oh, go ahead, Jay. Go ahead.
Yeah, that's a good question about the albumin testing. No, that wasn't done, but he did have carotid workup looking to rule out any vascular compromise that could be contributing to his cystoid macular edema. So I guess he had everything but albumin. I'm going to have to read up on that because I don't know. Other than the nutritional deficiencies, et cetera, I don't know anything about albumin relating to the eye.
Dr. Shovlin, I'm sure we'll type something here and then and we can read it to the group. We had another doc said, did you take the patient off of all of pressure lowering medications?
Yes. Yeah, we took him off all pressure lowering medications. Once I did the diurnal and was convinced that his maculopathy was related to fluctuating IOP, the last thing we wanted to do was to have him lower his eye pressure even more. So he came off all glaucoma medications and has his pressure, the highest pressure he's had in about 8 years was 26. But he does well with 1 drop of prednisolone every day.
And Jay, I want to point out too, I think that, that laser scar that you keep referencing in that left eye, probably like you said, for that choroidal neovascular, that peripapillary choroidal neovascular membrane, just barbecued that papulomacular bundle, and they just have poor acuity. That's just, that would be, if that wasn't there, I bet you that acuity would be a little bit better. So.
Yeah, I agree. And I bet that if that wasn't there, his visual field testing would be okay. Because if you remember what the right eye looked like, he had some laser treatment done kind of inferior macula. He had like a superior pseudo arcuate visual field loss. And I think it was from that laser treatment as well. Although his clinical history, he didn't mention that he had laser in the right eye, but we knew he had. So I would agree, I think. And so that's a good point of, when you're doing visual fields and, it seems strange because his optic nerve didn't look bad. And that's a good point, Greg. And, clinical correlation, your visual field has got to match the structure, right? So go back to the eye and find out, is there anything else that could be contributing to the visual field? And I was convinced from the beginning it was his laser spot. So he's very, very happy. I didn't tell you his what he did for a living when he came and saw me. His vision was terrible, right? And if you go back to the diurnal that I did, his vision was best, between the hours of like 12 and 2. This man was a dump truck driver. He drove a dump truck in Ocean Shores, Washington. And I told him, I said, sir, you need to find a new career. You can't be driving a dump truck 60% of the time. You're almost legally blind. But he's been a good sport. I've had fun with him. So that was kind of an odd case. But it just brings to mind that when things don't make sense, sometimes adding more medication doesn't do the trick. So let's move on.
Hold on 1 second.
Before we move on, Jay, Dr. Chauvelin just mentions that low albumin levels, especially other contributing factors, can give macular edema. Somebody asked, why no communication with the glaucoma specialist?
Why no communication with the glaucoma specialist? There was communication with the glaucoma specialist. I talked to the glaucoma specialist on a number of occasions and was continually told, Jay, if you keep pushing his pressures into the 20s, he's going to go blind. So he warned me, stop doing what you're doing. And so, of course, I have the advantage of, working with retina MDs. And so I ran the case by the retina MDs, and they were in complete agreement. I mean, they were like, Jay, it's pretty obvious. You've documented that hypotony is causing his macular edema. Let's just track him. I mean, you got to do diligence and follow the glaucomatist part. But, I think the glaucoma doctor was just so hung up on, the visual field loss was so advanced that he couldn't see the forest through the trees.
And Jay, a question came in. When do you suspect sleep apnea?
That's a good question. I do have, and I'll pose this to Greg and Joe. We've got about 30 minutes to go. I've got a great sleep apnea at the end of this. I think we'll get to it, and it will pretty much answer any question that you have about when to expect sleep apnea.
Okay.
Should we just roll through the talks?
Sure.
All right, here we go.
There's one question, Jay. Just make sure we get to the questions because these are supposed to be live and interactive. We'll make sure we meet all COPE. It says, what at-home IOP testing would be beneficial? I think it's supposed to be Diaton or Tonopen. And there is an at-home by Eye Care. That would probably be the best way to go, would be my answer to help you out.
Yeah, I was going to say the same thing. I don't know much about the at-home, but I would agree with the Eye Care one.
Okay.
Yeah, because the Diaton and the Tonopen will require some significant skill.
Right.
It's transdermal too, right?
Diaton
yes.
is, yes.
Yeah. Okay. Yeah.
Okay.
All right.
That's all. We're all caught up. Go to it, my friend.
All right. So let's show a couple of cases of MS or not MS. Now these next couple of cases are quick, and they're gonna highlight the importance of looking at other features of OCT than just the radial B scans that you get, and more importantly, looking at the ganglion cell complex. So, MS or not MS? Well, she's got MS. You know, we look at her medical history, she's got MS. So why are we talking about MS or not MS? And I'll tell you why. So this is a 36-year-old female. She has MS. She develops blurry vision in the left eye for 8 months. She called her neurologist. The neurologist said, you know, Julie, this is another event of optic neuritis. Give it time. It's likely going to get better. So she did. And after 8 months, she saw the optometrist. The optometrist said, I don't know why you can't see in your left eye. Go see Jay. So she came and saw me. Visual acuity was down in the left eye. Everything else was good. What additional tests do you consider in young patients with MS who have suspect optic neuritis? If we go back, I'm going to point out the no RAPD. So when I see patients, I don't check their pupils on an entrance test. My techs do it. But when I have a suspect case where I know that they should have had an afferent pupil, I always bring them back and check their pupils on the next visit. And this lady did not have a relative APD under my watch. So this is probably the most expensive test that we've all invested in. It's your bottle of tropicamide. So the red cap test is a very gross test, but it can highlight desaturation in patients with clear-cut optic nerve disease. She had a little bit of desaturation, but nothing that I would contribute to an optic nerve disease at all. That loss of 10% contrast could be her drop in acuity. So we look at OCT as she's got reduced vision. These are the B scans that we got. This is the right eye. Very, very normal. I don't see anything here that really jumps out as being atypical at all. Here's the other eye. Looks good to me. So when you have a case of decreased functional vision and you run an OCT and everything looks fine, go one step further and look at the ganglion cell complex. So this is with Zeiss. We look at the ganglion cell complex and we can see in the left eye that she's got a clear reduced thickness of the retinal ganglion cell in the left eye. So now we have structural changes that are matching visual symptoms, okay? So she's got ganglion cell thinning on the left eye. Did you know that the retinal ganglion cell and inner plexiform complex is far more sensitive to the demyelination process of MS? It's a prognostic marker in the expected quality of life and visual outcomes in patients, and it's become very, very standard in my region that neurology is referring patients to providers with OCT to look at ganglion cell thickness on a yearly basis just for this reason, because a lot of neurologists will treat MS patients and then they won't alter therapy unless patients either don't respond or they have progression on MRIs. But by the time you have another lesion show up on an MRI, it can sometimes be a year or 2 or 3 years down the road. But the retinal ganglion cell is much, much more common. So she had thinning of the ganglion cell secondary to MS, no evidence of optic neuritis. She's got what's called retrograde demyelination. Instead of the demyelination impacting the nerve and going back to the occipital cortex, it's coming anterior from the brain to the retina. So she's losing ganglion cell. Now the neurologist said, Jay, she's going to eventually develop optic neuritis and go blind in this eye. And I would not disagree with that. This second one is a patient. She's 30 years old. She's convinced she has MS. She's a nursing student. She developed a blurry smudge off to the center of her vision in the left eye. She had a little bit of discomfort. She didn't have any real pain on rotation in my office, but her symptoms was she had a little discomfort. She probably Googled 30-year-old nursing student with a blurry smudge in vision and pain on rotation, and it came up with MS. But she was convinced she had MS. So she goes to the optometrist. He refers to me. He can't explain why she's having vision loss. Not only did she have decreased vision in the left eye, she also was down in the right eye too. Anterior segment looked good. Red cap desaturation. Little bit more desaturation in the left eye on this one. So now we're thinking that maybe she does have some degree of optic neuritis. Maybe she does have features that warrant testing for MS. These are visual fields that I obtained after the consult. I don't have visual field testing. I leave that to my optometry colleagues. But if we look at her visual fields, here's her left eye. She did have a definitive smudge. She's got a paracentral defect. Reliability indices are good, but she also had like a pseudo early arcuate change in the right eye, which she had really no visual symptoms of. Here's her OCTs. This is where the referring doctor stopped. Jay, I got OCTs. They look perfect. I said, did you look at the retinal ganglion cell? He said, no, that's what you'll do for me. So he sent me the patient. Here's her ganglion cell complex. Now, I will tell you that if we look at colors, I mean, I'm not a big fan of looking at colors. I know that colors are good, you know, red, yellow, and green. If you just look at the thickness maps for ganglion cell, it's still pretty normal. But if you look at the pattern of and the density of thinning in the paramacular area of the left eye, this ganglion cell thinning matched precisely to the visual field loss that she had. So I told her, I said, you know, you've got thinning of the ganglion cell, which can occur for a number of reasons. MS is on the list. You've got visual fields that document a central scotoma. Let's watch this and see what happens. She says, why would we not get an MRI? I said, well, I called my neuro-ophthalmology specialist and said, you know, without true optic neuritis, nobody's going to do an MRI anyway. She says, Jay, I want an MRI. Okay, go get an MRI. She got an MRI. It was negative. MS lesions. She had a normal MRI scan, which is not surprising. And at that point, she says to her primary care doctor, I want a spinal tap. Primary care doctor says, your clinical case does not warrant a spinal tap. It's too risky. She says, I think I have MS. I want a spinal tap. Sure enough, the spinal tap revealed elevated protein consistent with optic neuritis. Now, she did not have optic neuritis per se because she had a normal pupil response. I think she has one of these retrograde demyelination. I could have missed the APD too, but it just goes to show you the sensitivity of ganglion cell thinning related to demyelination. So once she had the spinal tap, the neurologist said, look, you've got a normal MRI. We're not going to treat you with methylprednisolone, which would be standard for, you know, patients with MS lesions. She says, I want to be treated with IV methylprednisolone. She was treated with IV methylprednisolone, followed by prednisone, which is the standard treatment for optic neuritis. She saw me for one follow-up visit. Acuity was still down in the left eye, but had a notable improvement in contrast sensitivity. She was happier, and she said, I'm going to get an MRI every 6 months because I don't want to develop MS-like complications. And if I start having MS changes, I'm going to be treated. I never saw her again. So if she pops up in one of your regions as a nurse practitioner, tell her I said hello. So let's go to Paul, question number 5, true or false?
And Jay, this kind of just, you're probably not aware, but Dr. Mesner, Len Mesner from ICO, you know, the neuro guru, has, you know, highlighted last week, you know, the importance of GCC in kind of chiasmal lesions. He did touch on the MS. So, you know, it's kind of neat that how sensitive this ganglion cell, not the retina, because you showed a retina there, but then you quickly went into showing how important it is to scan that GCC, and listening to people like you and to Len Mesner has led me to, on these kind of uncertain conditions, to scan that GCC, and that can really unravel a lot of mysteries out there. So thank you for bringing that up.
Oh, sure. Now let me just give the audience a little pearl on GCC. You know, we're living in the era that we are dilating our patients less and less because of technology and wide field imaging, etc. Good, 99%. I like it. The audience is sitting upright and listening. Perfect. Or they had a 50-50 chance. You know, my son told me that I have validated the 50-50-90 rule. Greg, do you know what the 50-50-90 rule is?
No, help me out with that.
Okay, now this is me. When given a 50-50 chance, 90% of the time, I guess wrong. All right, so back to the ganglion cell. If you're going to look at ganglion cell analysis, you need to have a pristine scan. You can't have a low signal strength. So make sure you dilate your patients and get a very, very high quality scan, or you will see some image artifacts. And just for the audience, I didn't put this in here, but there are known entities that cause documented thinning of the retinal ganglion cell. Okay, so if you've got a pen and paper, or maybe you can throw this in the chat. MS is one, glaucoma is the other. We all know glaucoma. Okay, other entities which can cause thinning of the ganglion cell: Parkinson disease, widespread thinning of ganglion cell, myasthenia gravis, neurogenic, widespread thinning of ganglion cell, Alzheimer's and dementia, widespread thinning of ganglion cell, stroke, and chiasmal lesions will give you that. So stroke, you'll actually get a GCC that looks exactly like the homonymous heminopsia. It's really kind of cool looking at that stroke. And then the final one, which there's not a lot in the literature about this, but it's ADHD. ADHD can give you thinning of ganglion cell. And the question is it actually ADHD, or is it a long-term complication of Adderall? I don't know. But as a take-home message, knowing that we have Alzheimer's and dementia on one end of the spectrum, and we've got ADHD on the other, for those of you who are looking for a new young associate in your practice, look at their ganglion cell level, and please don't scan your mother-in-law, because you don't want to know, right? All right, here we go. We've got.
So Jay, just so you know, last week, one of the pearls we picked up is when we talked about stroke being behind the lateral geniculate body, it could maybe take 6 to 8 months, maybe to a year to show up. But when it's before the lateral geniculate body, it could show up within 2 to 3 months. So kind of a timing thing that's there. And I like giving these comments for you because I just saw you take a drink there, and gives you time to kind of inhale and exhale, so you don't have to keep talking. So
exactly.
All right. This looks like a beautiful part right here.
So we're going to close with sleep. Some of you, have heard me lecture, I'm a huge advocate of sleep apnea, and I'm going to try to teach you how to kind of snuff this out in your patients. So is sleep really overrated? Perhaps not for some. So this is the very first patient that I worked up and looked at sleep apnea as being potential contributory to his chronic macular edema. So he presents as a standard diabetic with macular edema. He's got decreased vision that's been going on for about 6 months in his left eye. He has no complaints in his right eye. Medical history: type 2 diabetes, hypertension, hyperlipidemia, unknown hemoglobin A1C, says he doesn't check his glucose regularly. That's a big surprise, right? This is what all of our patients tell us. Blood pressure was borderline. Visual acuity down in the left eye. Also a little blurry in the right eye, but he wasn't too worried about his right eye. Everything else looked good. Okay. Here's the fundus photo. 11 years ago. Boy, hasn't fundus photography come a long way in 11 years. Holy smokes. So here's the fundus photo. And, just looking at this fundus photo, we can tell in his left eye that he's got kind of a blurry macula and he's got circinate lipid. So we know, we even knew back in 2009 that this patient had, significant macular edema. And all we had in 2009 was stratus OCT. Boy, haven't we come a long way with OCT. But I keep these in here because obviously it matches my patient, right? But it just goes to show you where we've come with OCT. So the OCT images, even, as poor as they were, we thought they were good then, but even as poor as they were, you could still see cystoid change in the right eye and significant cystoid change in the left eye and also subretinal fluid. So even with time domain, you can still, see pretty significant macular edema. There's the thickness maps. We've all come to love thickness maps, and I use thickness maps a lot for patients with diabetes because it really tells a better story than just one B scan. So let me just tell you what we did. So back in 2009, all we had was Avastin and steroids and laser. We were still doing laser for macular edema. So the patient was treated with triamcinolone, Avastin, and laser. Came back 4 months later. Vision in the right eye improved. Vision in the left eye got worse. And now he reports his A1C is 6.1. I actually called the endocrinologist and confirmed this. So despite retinal findings, his diabetes was in very good control. That's flag number 1 for sleep apnea. All right, here's his color photos 4 months later. Lipid going away. Right eye looks great. Lipids going away in the left eye. But look at his OCT. It got worse in his right eye, although he claims his vision is better. His left eye, maybe this is a little better, but still has significant macular edema. So here's what we did. So over the context of time, my retina doctors would treat him, and we were not treating both eyes on the same day. So he was alternating one and the other. So on this day, October 2009, so we're 4 months into this now. He had reduction in macular edema of the right eye and he got worse in the left eye. So he was given what's called an IVAC, intravitreal Avastin Kenalog, number 2, same day, anti-VEGF and steroid. Comes back for a follow-up. His left eye is getting better. His right eye is holding stable. Everybody's happy. Let's just watch. And these follow-up intervals are about 6 weeks. So he comes in February of 2010. He's got recurrent macular edema in both eyes. Now remember, his diabetes is well controlled and his blood pressure's okay. All right. So he was given a combination treatment in the left eye on that day. Left eye's better, right eye's worse. So he was treated in the right eye on this day. Look at your thickness maps, audience. Right eye's better, left eye's worse. He was treated with an IVAC in his left eye for number 4. Left eye's better, right eye's worse. So he's about 8 weeks from treatment in the right eye, getting worse again. Retreated in the right eye. Well, that didn't work. Both eyes are getting worse. He was treated with a combination in the left eye again. His vision in the left eye now has dropped to 2400, and the vision in the right eye is holding at about 2040. Okay, so clearly out of control. That didn't work, and so this is where the retina doctor got nervous, as did the patient, and so he went with a bilateral injection. Both eyes are getting worse, bilateral injections. Unfortunately, you do things long enough, something bad's going to happen. He developed a steroid-induced response. So Kenalog is now off the board. He's got profound macular edema. He's 2100 in the right eye and he's 2400 in the left eye. He had bilateral Avastin on this day, which is really all we had. He comes in for follow-up. Maybe he's a little bit better, but the retina doctor said, I don't know what I can do for you. And the patient said, I'll tell you what I'm going to do. I'm going to go back and see Dr. Haynie because he told me that if I did what I was supposed to do, I would not lose my eyesight. And I do tell patients that, you know, we have great treatment for diabetic retinopathy. And if you're compliant with your diabetes and you do what we ask you to do, there's a high probability that we can maintain visual function. So he comes back and sees me and he says, I'm done with shots. I'm basically legally blind. What are we going to do now? So I looked at his medication list. He was not on Avandia or Actos. He wasn't taking niacin for cholesterol. He wasn't on any prostaglandins for eye pressure control, which, by the way, if you've got a diabetic with macular edema and they need glaucoma therapy, don't put them on a prostaglandin. Put them on like a Cosopt that has dorzolamide in it, because that also helps macular edema. But just try to avoid the prostaglandins in patients who are being treated for macular edema. So the question was, now what? Well, about 3 months prior to him coming back to me, I was on a plane reading about sleep apnea. I'm not sure why I was reading about sleep apnea. It might have been the journal that the guy before me left on the plane. And I was reading about hypoxia, and I didn't have anything to do with the eye, but I thought, wait, if the RPE requires oxygen to function as a pump, and we know from Jeopardy that the organ in the body that requires the most oxygen to function is the retina, maybe sleep apnea, maybe this patient's hypoxic. Maybe that's why the compounds work, because you stimulate the RPE, but then when the meds wear off, he blows up again. So I'm going to order a sleep study. First person I ever referred for a sleep study, and he was diagnosed with severe obstructive sleep apnea, treated with standard therapy known as a CPAP. Now, I will also tell you that this patient's body mass index was about 27. He did not have features of sleep apnea. We think about, clinical obesity. We think about, neck circumference over 17 as features. But I will tell you, ladies and gentlemen, it doesn't have to be that way. So I referred him for a sleep study. Guess what happened? Here's a year after sleep apnea testing. Macular edema in the right eye. He's got a little residual cystoid changes. We updated to Cirrus at this point from time domain. Left eye looks better. He's got a little bit of an outer retinal change here from laser, but clearly looks much, much better. This was a year later with no intravitreal injections. His vision went from, his vision's 20/20 in the right eye and about 20/40 in the left eye. So he ended up really, really well treatment. Here's another case. Diabetic macular edema proven refractory. This is a month, and this is 3 months after sleep apnea therapy. Okay, so when do you consider sleep apnea? So I consider sleep apnea, and we'll go through some other retinal diagnoses here, but in your diabetic patients, you want to consider sleep apnea when your patient responds to treatment, but then develops recurrence shortly thereafter, just like our patient. Retina doctor treats them, macular edema goes away, retinal edema comes back. Keep in mind the factors of control of diabetes. If their diabetes A1C is 14, their blood sugars are 600, that's probably coming into play as well. But patients with good systemic management of disease, poor response to therapy, think sleep apnea. The retinal edema becomes refractory to treatment, refractive to treatment, meaning it just doesn't respond. What does the retina doctor generally do in this regard? Started with Avastin, now they're on to Lucentis or Eylea. So your second clue is when you get your doctor, the referral note from the retina doctor back, and it says, we've now switched your patient from Avastin to Lucentis because they failed to respond. That's your second clue. And then the final clue is just full-blown tachyphylaxis, meaning they don't respond to anything long-term as our patients did. All right. Other reasons to consider sleep apnea: ischemic optic neuropathy. Almost every one of these patients describe, I noted vision loss after I woke up, whether it was from a nap or going to bed. They all have vision loss after sleeping. what happens with sleeping? Your blood pressure drops. If you have sleep apnea, it's going to cause hypotension and hypoxia. So I think sleep apnea on every case of non-ischemic anterior ischemic optic neuropathy. Get a sleep study. Cotton wool spots. Cotton wool spots are an ischemic event in the retina. We know that. This is a patient who's diabetic. This is a patient who's got an A1C of 5.5. Blood pressure is normal. Now, why would you have 25 cotton wool spots? So if you've got multiple cotton wool spots in your patients, consider sleep apnea. Central serous. 67% of patients with recurrent central serous have sleep apnea. So in my central serous family, episode number 1 usually gets better. We know that. And it usually gets better because they address the stimulants, they stop the caffeine, they manage their stress, they avoid their steroids, and they come back with recurrent central serous. Why is it coming back if they did everything you asked them to do? They're as frustrated as you are. The reason it comes back, 7 out of 10 have sleep apnea. So get a sleep study on episode number 2 in your central serous. And if you get any records from me, I always log my episodes of central serous, episode number 1. And when I get to episode number 2, they get a sleep study. Other things to look at as keys to sleep study. This was a featured article looking at OCTA, and what did they look at? Larger foveal avascular zones and venous tortuosity. So when you're doing OCTAs on patients, especially diabetics, if they've got a large foveal avascular zone, think about sleep apnea. It's an ischemic maculopathy. So I went back and got some of my sleep apnea patients to look at OCTA because I had no idea about this. This is me. This is my OCTA, and I think I look pretty good. But here's my sleep apnea patient. This is your avascular zone here. It's about 1.5 times larger than mine. Here's another one. Starting to get loss of capillary plexus, enlarged FAZ. This could very well be sleep apnea. There's another one. These are all patients who are diagnosed with sleep apnea. It's probably one of the most underdiagnosed entities, and it can exacerbate a lot of stuff. So let's go through some final comments. It's a lot more common than we think. Put it on your medical history form. Not only put it on your medical history form, ask them if they're treating it. Know the retinal findings of complications, ischemic optic neuropathy, chronic central serous, refractory macular edema, esophageal reflux. Very, very common in your sleep apnea patients. Okay? And educate the PCPs when you're suspicious. This pops up in my EHR system. It's in your notes. I won't read it to you, but this is a smart phrase that gets dumped right into my EHR system. So what is the incidence of sleep apnea and why should we worry about this? It mimics that of AMD. 1 in 4 men, 1 in 10 women have clinical findings consistent with some degree of sleep apnea. So 1 in 4 men, 1 in 10 women, and you all have these patients in your practice. Follow up on the study to make sure it ever got done. Anytime I order a sleep study, I always see the patient back in a month just to make sure it gets done. Be the advocate for your patients. There's a lot of complications of sleep apnea. And let's finish with our final poll question. What is the incidence of sleep apnea?
And Jay, just so everyone knows, way back early, I'll scroll back through. The timing was 7:20 is when I put the handout out, and Jay was kind enough to make it the full slides that are out there.
Yeah. Now, while we're talking about this poll question, I will tell you the cheapest sleep study that you have is your voice. So here's what I do. When I think a patient has sleep apnea, I ask them, do you ever wake up in the morning with a headache? So if you've got retinal features, you're worried about sleep apnea, do you ever wake up in the morning with a headache? Do you find it necessary to take a nap. I'm 55. I like to take naps, but they're not necessary, right? So if you find it necessary to take a nap, do you snore? Make sure you ask the wife sitting in there, because the husband always says no. And the final one is, do you suffer from acid reflux and heartburn, chronic heartburn? And if they answer yes to 2 of those 4 questions, headaches, naps, snoring, and reflux, they probably have undiagnosed sleep apnea. 1 in 4 men, we got it. So as we kind of close and talk here, I just want to show you where I'm going to be in 2 weeks, provided we can get into University of Washington. This is the greatest setting in college football, Seattle, Washington. How beautiful is that?
Yeah, that's awesome. I've been to that university and walked on that campus, Jay. That is a beautiful campus.
Yeah. And if there's any questions by the audience, you can reach out directly to me. My email address is on the bottom, drj@soundretina.com.
You're just getting your virtual accolades. Jay, is that your last slide?
That's my last slide.
So I'm going to have you stop sharing.
Oh yeah, I forgot to stop sharing.
That's all right. No biggie.
I knew I'd forget something.
It's a nice picture though, look at.
We're going to put this one up. We're going to thank you. But I do have one more polling question. And Jay, I hope you don't mind if I take this a little personal. I just want to know how many people out there are cancer survivors. Or and this is all anonymous, and I understand it might be some HIPAA, but we don't get any data out here. We just have to show percentages. And as these are rolling in, Jay, how long has it been? Well, you showed up to the academy and you didn't look so well. How long ago was that?
Well, what is the date today? August 22nd?
Yeah.
I started treatment for cancer on August 9th of 2011. I just surpassed my 10-year cancer-free anniversary. Thanks for asking, Greg.
Yeah.
Congratulations.
I remember you showing up to the academy or one of the meetings. Maybe it wasn't the academy, but you showed up. You didn't look so great. You went back and you find out that you had cancer. And
it was Salt Lake City. It was optometry's meeting.
That's what it was.
City.
That's what it was. Optometry's meeting in Salt Lake. That's it.
Yeah.
And you didn't look so great, but you did the lecture. You came back, then we heard you had cancer. And you have a lot of good work to be done, as you did right here tonight. So congratulations on the cancer surviving, and thanks for being here tonight.
You bet.
So you got 11 colleagues out there, Jay. So you're not alone. So congratulations to everyone that's out there as being treated or currently being treated. Jay, you did a great job here. Thank you for being here tonight. Doesn't look there's any more questions in there. You're just getting great CE. Congrats, you're getting your virtual accolades. That will conclude the CE for tonight. That was Retinal Grand Rounds. That was by Dr. Jay Haynie from Washington. And as always, Joe and I were here to moderate, and Vanessa as our COPE administrator, along with Daisha that was here tonight also.